We're grateful to have two hematology-oncology experts with us this evening. Dr. Curran from University of Cincinnati will be presenting on adult ALL, followed by a Q&A facilitated by Dr. Justin Klein from the University of Chicago Medicine. He's also our chair of our medical advisory board. Dr. Curran, I'll turn it over to you.
Thank you so much. I'm going to share my screen quickly. Okay. Thank you guys so much for joining us this evening. Today I'll be talking about acute lymphoblastic leukemia in adults and focusing on some of the new and emerging treatment options for ALL. Here are my disclosures. And so this is going to be a review, I think, for most of you, but just to kind of review the classification of our leukemias and particularly our acute leukemias. So our acute leukemias, which are AML and ALL, are really diseases of stem cells. So cancers of either our myeloid stem cell, as in the case of AML, or the lymphoid stem cell, as in the case of ALL. And then when we talk about acute lymphoblastic leukemia or ALL, it gets further subdivided. And this is important because it really determines some of our treatment approaches. And so within ALL, we can further subdivide this disease into either a B-cell ALL or T-cell ALL. Now, importantly, our B-cell ALLs tend to express markers such as CD19 and CD22, which I will go into later on in this talk because it does have implications for some of the newer treatment approaches. And then within B-cell ALL, we have both the Philadelphia chromosome positive and Philadelphia chromosome negative. So when I am approaching somebody with a newly diagnosed ALL, that's kind of how I divide it in my mind when I'm coming up with a treatment approach. Now, I think a lot of us think of ALL as a disease of children, and it is. I mean, the median age of diagnosis for ALL is only 17 years of age. But if you look at this graph on the left, you'll recognize that approximately half of patients with ALL are actually diagnosed in adulthood. And importantly, about 87% of the deaths of all patients with ALL occur in adults. And so this is, actually a fairly under-recognized disease in adults, and unfortunately at the current moment has a fairly poor prognosis. But I think we're making progress, and that's what we're going to be talking about today. And so I think one of the inspirations for adult ALL is looking at the improvements that our pediatric colleagues have made amongst children with ALL. And so if you look at the improvements over the course of the past 50 to 60 years, it's really quite impressive. So a child with ALL diagnosed back in the late 60s, early 70s had less than a 10% chance of being alive at 5 years, so pretty poor. But now 2006 to 2009, and I think it's even improved over the past 10 years or so, we're talking on the order of telling a young patient with ALL these days that they probably have a 90 to 95% chance of being alive at 5 years. We haven't quite made the same degree of improvements in our adult patients with ALL, but I think we're getting there, and that's what I'm going to be kind of reviewing today. During the next 20 minutes or so. And so first, I'd like to kind of an overview of the talk. So first, I'd like to review some of the recent progress that we've made in the treatment of adults with ALL. And then go over some of the newer kind of emerging treatment approaches for ALL, where I think the field is probably going in the next 5 to 10 years. And then very briefly at the end, going over some of the unanswered questions I think that are in the field. And then we'll conclude with a questions and discussion session. So when I think about recent progress in ALL, I think one of the areas that really kind of comes to mind is where we've made really significant improvements is in our adolescents and young adults with ALL. So this is typically defined as patients age 16 to 39. And I think this is an important age group because, as mentioned before, our children with ALL tend to have very good outcomes. So 90 to 95% survival rate. But when you increase in age, even down to the age of 15 to 39, that drastically drops off and it continues to decrease throughout the age range. And so a lot of work has gone into really understanding what some have termed a survival cliff, where there's really this drastic drop off when you go from a child with ALL to an adolescent or a young adult. It's probably multifactorial, but I think some of the reasons are probably differences in treatment approach, which I will go into in more detail. These patients probably also have worse disease biology. And then, as we all know, our young adult patients, as you're transitioning from being a child under the care of your parents into an independent young adult, there's a lot of new issues such as, getting your first job and not having health insurance and trying to figure out transportation and all of those sort of things that can make it very difficult to be able to get these treatments. And so I think that's really an important approach, an important component. But what I'm going to focus on here is the differences in treatment approach, because that's where we've really made some progress in the recent probably 5 to 10 years. So one thing that's really interesting about this young adult age group is that the treatment that, for instance, an 18-year-old will get really depends on where they're treated. So an 18-year-old could either be treated at a children's hospital or just as relatively be treated at an adult hospital. But which place that they go to really determines, at least up until recently, has really determined what kind of treatment they get. And so this was a study by Dr. Muffley and colleagues looking at the California Cancer Registry. And so they looked at patients aged 15 to 39 with acute lymphoblastic leukemia. And they found that if you were in this age range and you walked into a children's hospital for your treatment, 100% of those patients got what is termed a, quote, pediatric regimen. So a regimen designed for children with ALL. Versus if you walked into an adult hospital, less than a fourth of those patients received what's called a pediatric regimen. So why does this matter? Well, we know from historic data that actually patients who are treated with these pediatric or these childhood ALL regimens, it seems that they have better outcomes than patients who are treated with adult regimens. And so this was studied in a prospective manner in almost 300 young adult patients with ALL, age 17 to 39. And they found that of those patients who were treated with one of these pediatric or childhood regimens, about 90% of them went into remission. So 90% of them were leukemia free at the end of the first round of treatment. And importantly, almost 3/4 of those patients were alive at 3 years, and about 60% of those patients still had no evidence of leukemia at 3 years. This was much better than when you look back and look at patients who were treated with an adult regimen. In those cases, those patients, there was only a 34% of them had the leukemia or were still free of leukemia at 3 years. And so this was a significant improvement. And it's been replicated both within the United States as well as across the world. And so now I think many people will now preferentially treat anybody, a young adult patient with ALL, will treat them with what's called a, quote, pediatric regimen or childhood regimen. And with these newer regimens, the hope is that the outcomes of our young adults with ALL will significantly improve. Now, I think another area where we've really made a ton of progress is in the treatment of relapsed or refractory B-cell ALL. So meaning patients who have B-cell ALL where either the disease did not go away with treatment, or it went away and then it came back. And so we know, again, historically, patients who have ALL, when their disease comes back, it's really a poor prognosis, unfortunately, with patients in this, who have their ALL come back. Only about 7 to 8% of them are alive at 5 years. Now, that was historic data, and over the past decade or so, we've had a bunch of new treatments that have been approved for relapsed and refractory ALL. So it's really been quite exciting. I'm going to go into some of these in detail, but they include blinatumomab, inotuzumab, and CAR-T cell therapy. And so the first I'll be talking about is blinatumomab. So blinatumomab is what's called a bispecific T-cell engager, or BiTE antibody. And this BiTE antibody, the way it works is it has one side of it is targeted towards CD19, which is on the surface of the leukemia cell. Now, again, as I mentioned before, only the B-cell ALL has CD19 on it. So this is a treatment for B-cell ALL and not T-cell ALL. So this bispecific, this BiTE antibody will bind to the CD19 on the B-cell ALL, the leukemia cell. And then it has another side to it, which binds to CD3 on the healthy, normal immune T cells. And what this does is it's thought to bring these two into close proximity so that the healthy immune cells can kill the leukemia cells. In a large study looking at this treatment, it's called the TOWER trial, they had over 400 patients with B-cell ALL that was either relapsed or refractory, so didn't respond or had come back. And they randomized them, so flipped a coin to either get blinatumomab or to get standard of care kind of traditional chemotherapy. And what they found was that amongst the patients who got blinatumomab, almost half, or 44% of them, went into remission, so got rid of the leukemia, as compared to only about a fourth who had received the chemotherapy. And importantly, amongst the patients who had received blinatumomab, they survived longer and were leukemia-free for longer. And so this drug is now approved for the treatment of relapsed and refractory ALL. Another really exciting advancement and a fairly newly approved drug is a drug called inotuzumab ozogamicin, or INO. This is what's called an antibody drug conjugate. So it has an antibody that will bind to CD22 on the surface of the leukemic B cells. So again, also only a treatment for B-cell ALL, because these cells are the ones that express CD22. So the antibody binds to CD22 on the surface of the leukemia cell. Attached to this antibody is a chemotherapy that, when it's activated, it's too toxic just to get through the vein. So it's bound to this antibody in an inactive form, so you can safely give it through the vein. Once it binds to the leukemia cell, it gets engulfed by the leukemia cell, and when it's inside the cell, the chemotherapy actually gets activated once it's inside, and so it directly kills the cell once it's inside of the cell. Around the same time as the blinatumomab study was the INOVATE study, which had over 300 patients, again with relapsed and refractory B-cell ALL. And here the patients were, again, randomized, flip of a coin, to either the inotuzumab or chemotherapy. And here you can see, again, the response rates were much better than the chemotherapy. So in this particular trial, over 80% of patients who were treated with the inotuzumab went into remission, as compared to less than 30% of the patients who got chemotherapy. So much better with the inotuzumab than the chemotherapy. And similar to the blinatumomab, the patients who got the inotuzumab were more likely to be alive for longer and were leukemia-free for longer. And then finally, one of the other exciting new treatments that has been approved over the past decade for ALL are the CAR-T cells, or chimeric antigen receptor T cells. And these, the way that these work are in a patient with leukemia or other hematologic malignancies. These have been approved for other blood cancers as well. But in a patient with ALL, they collect the blood, the healthy immune cells, so the T cells, and then take them out of the body, engineer them to have this receptor against CD19. So again, this is going to be targeted to that CD19 on the surface of the B cells. So these are only effective for B cell ALL. They engineer them to express this receptor and then put them back a couple of weeks later, put them back into the patient. And then once they're in the patient, these T cells go to the leukemia and attack it and kill it. I'm not going to go into all these details, but there have been a bunch of trials of CAR-T cells for ALL. They've all shown, though, that around 80 to 90% of the time, they get rid of the leukemia. They put patients into remission. There are some toxicities with the CAR-T cells, such as cytokine release and neurotoxicity, which have to be managed. I think we're getting better and better at managing those, but generally, for the most part, a lot of times these patients are in the hospital for at least a portion of this. A couple of years ago, Kymriah was approved for pediatric and young adult patients with ALL. But about a year ago, based on the results of this ZUMA-3 trial, another CD19 CAR therapy, Tecartus, or the Kite-19 product, was approved for treatment for adults with ALL, so 18 and above. And so this really kind of gave a CAR T cell option for our adult patients with ALL. In this particular trial, they treated 55 patients and showed a response rate of about 70%. So about 70% of the time patients went into remission. And in general, that lasted around a little bit over a year. And so this is kind of the most recently approved treatment for again, B cell ALL, but was an exciting, another exciting option for relapsed and refractory ALL. And so with that, we do have several now treatments if the disease has come back, and hopefully we'll be continuing to improve upon the outcomes of patients with relapsed ALL. So that's the progress we've made, which I think is pretty significant for the past decade. But now I'd like to talk about where we're moving and some of the emerging treatments for ALL. So one of the areas that I'm most excited about is taking those new agents that I just described and using them earlier on in treatment and incorporating them into the initial diagnosis to try to improve outcomes and keep the leukemia from coming back. And so that's one of the approaches that we're doing in young adults with ALL, where we're using those pediatric regimens that seem to be effective for young adults with ALL. And then adding in a novel agent, in this case, it's inotuzumab, to see if by adding that into treatment, we can improve the outcomes of young adult patients with ALL. Now, I think where we really have a lot of room that we need to improve upon is in our older adult patients with ALL. Because unfortunately, these patients have poor outcomes. Historically, in patients age 60 and above, only about 13% of patients, older patients who are diagnosed with ALL will be alive at 3 years. And it's even worse for patients above the age of 75, where only 10% of patients are alive. And unfortunately, as compared to that really nice curve that I showed amongst the pediatric patients, where the survival just keeps on improving and keeps on improving, we really haven't made much progress in the survival amongst older adults with ALL. But I think we have some new and more promising treatment approaches that hopefully will kind of move this forward. I think part of the problem is that there's multiple challenges to improving outcomes of older adults with ALL. One is that these patients tend to have worse disease. So they are less likely to go into remission with treatment, more likely to be resistant to chemotherapy. And even if they do go into remission, they're more likely to have the disease come back. In addition, adults and older adults with ALL, unlike children, are more likely to have other medical problems. And unfortunately, a lot of the issues that we've run into in adult patients with ALL is that these treatments are very toxic, and oftentimes patients will die of the treatment and not actually of the disease. So the disease will be gone, but the treatment is what, the toxicity from the treatment will ultimately be what ends their life, unfortunately. And so we really need less toxic treatments. And then finally, kind of similar to our young adults, a lot of these ALL treatment regimens are very complicated. So without appropriate social support, it can be very difficult to get to and from appointments. Oftentimes, with some of these complicated regimens, patients need to come in several times a week. So one approach that has been taken by multiple trials is to try to minimize chemotherapy by using some of these novel agents. And so you can see here in this upper row, there's several ongoing trials using that drug inotuzumab, but using it in newly diagnosed patients. So before the disease has even come back, we try to use it right away in the upfront setting. Similarly, blinatumomab, that bispecific antibody that I discussed, has been incorporated into upfront treatment as well. And I think one thing that we're all really excited about is the potential with these new agents is, can we just get rid of chemotherapy altogether? And so one of the really exciting approaches is being studied in an ongoing trial in one of our big cooperative groups, where patients age 60 and above don't even receive any chemotherapy. They just get inotuzumab and blinatumomab. We don't have the results from this yet, but again, the potential of getting rid of chemotherapy, especially in people who are on the older side, is really enticing, and hopefully will improve outcomes for our older patients. Couple of special populations that I'd like to touch on is the Philadelphia chromosome positive ALL. So, and this is a particular, and I kind of highlighted this at the beginning, this is a particular subtype of ALL that's characterized by within the chromosomes, which are the instruction sheets for the cells, part of chromosome 9 gets moved over and put onto chromosome 22. And it results in this BCR and ABL being in close proximity to each other, and causes a fusion. So it causes the two basically to be stuck together. And what happens then is that you get this constant signaling, which tells the cell to grow and divide. Historically, patients with this particular subtype of ALL have worse prognosis than other subtypes, and this tends to be in older patients. But we know that there's several ways to target this BCR-ABL fusion protein, and those are called tyrosine kinase inhibitors. They were initially approved for CML, but incorporating them into treatment for ALL has improved outcomes. And so now I think many of us will argue that with the use of these, what are called these tyrosine kinase inhibitors, or TKIs, patients with Ph positive ALL don't have the same poor prognosis that they once did. But where, again, where I think we're all really excited is, again, to get rid of chemotherapy. Because we know, again, from that historic data that chemotherapy doesn't really work that well for this particular disease, this Philadelphia chromosome positive ALL. And so can we potentially minimize it as much as possible, or perhaps get rid of it completely? And so a lot of the ongoing studies are looking at that. One particular study that was really exciting, I think, to many of us, was using, again, that novel agent, blinatumomab, and then adding in a tyrosine kinase inhibitor, and having that be really the mainstay of treatment for Ph positive ALL. And you can see here that the outcomes are really impressive, with upwards of 80 to 90% of patients still alive at 2 years, which is much better than, again, what we've seen in the past. So, I think if we could, whether or not we can get rid of chemotherapy completely is still an unknown, and we're still looking at that. And I think understanding which patients we can do this approach in and which patients may require something more intensive is still kind of an ongoing area of investigation. But again, as with the older adults with ALL, I think the prospect of getting rid of chemotherapy, I think, is a really exciting possibility, and may even result in better outcomes than giving the more toxic chemotherapy. So I think in 5 to 10 years, we should hopefully have a better answer to this. And then finally, just a couple of more, another special population that I'm particularly interested in is a population, is a subtype of ALL called Ph-like ALL. So it behaves very similarly to that Philadelphia chromosome positive ALL that I described. And patients who have this subtype of ALL have worse outcomes than the patients who do not. Unfortunately, this subtype of ALL cannot be identified on kind of our standard testing, and so there's special panels that have to be sent out to identify this particular kind of ALL. But I think it's important because it really does affect our treatment approaches. And there's some ongoing studies looking at, we know that with this particular kind of ALL, just like with our Philadelphia chromosome positive, that maybe if we add in things like TKIs, those tyrosine kinase inhibitors, or other drugs that are approved, such as ruxolitinib, then maybe we can target some of the pathways that are activated in this subtype, and maybe improve the outcomes, similarly to what we did with Ph positive ALL. So those studies are ongoing to determine whether or not that does improve outcomes, but is kind of another area of investigation. And then finally, some of the newer treatments for relapsed disease. So one of the kind of away from the antibody and CAR-T cell therapy, I think one area that we're all really excited about is targeting survival signals. So in many cancers, we know that the cancer cells have signals that tell them not to die, even though they're supposed to. They have these extra signals that tell them to survive. And a lot of these are called, basically there's some that are, they're apoptotic signals. So we know that these are overexpressed, so they're at high levels in our leukemia cells. And so if you can target them, you don't directly kill the cell, but you allow it to die as it was supposed to. And so there currently are, one of the drugs that's approved for the other type of acute leukemia, AML, is called venetoclax, and that targets BCL2, and it's found to be very effective in patients with AML. And so there's several studies looking at this in ALL as well. And we think that just targeting one is probably not going to be enough. And so there was a study, which is shown here, looking at targeting a couple of these different pathways. So in this case, BCL2, and then another one, BCLXL. And so the idea, again, is not directly to kill the cells, but allow them to die. And so in this particular study, it was a very early study, but it looked really promising in these patients where no other treatment had really worked, and getting some patients into remission and having some patients survive for a year or more. So that's being studied using other drugs that are being developed to look at whether or not this will be an effective treatment. And then building upon the first part of the talk, there are efforts to develop new antibodies and novel CAR-T cells. So within the CAR-T cells, so the ones that I described, the ones that are commercially available, the ones you can get in clinic right now outside of a trial, are all targeted towards CD19, which, as I mentioned, is only on the B-cell ALL cells. One of the problems with this is that by just kind of targeting one thing on the cell, sometimes the leukemia cells get smart and they get rid of that CD19. And so there's a couple of different CAR-T cells that are being studied that will target different markers. So in addition to CD19, they'll also target CD22, or they'll target things that haven't been targeted before, like this TLSPR, which is seen in that pH-like ALL. So kind of different approaches to try to target different things on the cells. There also are now people developing CAR-T cells for T-cell ALL. So again, none of the things that I talked about outside of those targeting survival signals is really for T-cell ALL, unfortunately. But there are several groups trying to develop these CAR-T cells for T-cell ALL as well. And those are available on clinical trials at a few sites in the US. And then there's also efforts to try to develop new antibodies, so beyond just the CD19. And those include things like daratumumab, which is being studied, again, for T-cell ALL, to try to get rid of, or to help get rid of disease. So I think a lot of the work is really focusing, again, on CAR-T cells and some of these antibodies, but some other novel approaches as well. So that's kind of, I think where we've gone. I think where we're going is, I think, as I said multiple times, trying to get rid of chemotherapy as much as possible and use some of these novel approaches, and to really kind of refine some of these novel approaches. I think what we still don't know is, unfortunately, we don't have a lot of great treatments for T-cell ALL. We're working on them, but again, the majority of this talk was really geared towards B-cell ALL, and we really need better treatments for T-cell ALL, and we all recognize that and are actively working on that. I think another big question is when do we need to do a stem cell transplant? I think probably 10, 15 years ago, most patients with ALL, it would be recommended that they have a stem cell transplant, but now I think there's more and more evidence that maybe not everybody needs one, and trying to figure out who needs a transplant and who doesn't is really an ongoing area. And then I think we've got all these new treatments. How can we best incorporate them? Where should they be added in? How should they be added? I think is still an ongoing area of investigation. And so with that, I'm excited to take all of your questions and look forward to the discussion.
Thank you so much, Dr. Curran. That was very helpful. And we're going to move over to the Q&A session with Dr. Klein, as we said. A couple of you have typed some questions into the Q&A, which we will try to get to, and we had some submitted. So I'll turn it over to you, Dr. Klein.
All right, thanks, Carrie, and thank you so much, Emily, for joining us. I know it's late for you. So we appreciate your time. There's a couple of questions, one in the Q&A and one from the questions that were submitted before your talk about, excuse me, about blinatumomab. One has to do with how long remissions following blinatumomab treatment typically last, and is there anything that can be done to make the remissions more durable? Another person asked about the durability and was told by the doc that, these are typically remissions that last for a period of time. So any thoughts on those questions?
Yeah, I mean, I think, unfortunately, I don't think we have all the data yet. So when we talk about those different treatment options that for relapse disease, I think we all pretty much agree that inotuzumab does not result in long-term remissions. I mean, that was pretty clear from the data. Once you get about, a couple months out, most patients, the disease does come back. I think with blinatumomab, it's less clear because there are patients on blinatumomab where they're able to stay in a remission for long-term. And I think particularly in patients who get it earlier on in their disease course, where the disease hasn't come back multiple times. If they get it early on, I think some of us are hopeful that you could stay in remission for a long time. I mean, I think, so I guess there's a couple of different caveats to all of this. So I think one thing is, with the blinatumomab, most of the trials that are ongoing right now, you do it for somewhere between 4 to 6 cycles. We have had patients where they stay on blinatumomab long-term and stay in remission. We've had patients where we stopped it and they've stayed in remission, but we don't know, basically. And I think one of the big questions is also amongst patients, particularly, so I didn't even go into this, but amongst patients who get blinatumomab for minimal residual disease, meaning they went into remission, but there's a tiny little bit of disease left. We think that those remissions may last long-term, but we just don't know, and we don't have the data. So it was a long-winded way of saying we don't know.
So a follow-up question, and I posed the same question to Jen McNear in the previous session about childhood ALL. There are all these new bispecific antibodies, the antibodies that target B cells and T cells and sort of trigger the T cell to kill the cancer cell. There are all these new bispecific antibodies that have been developed in other B cell cancers, and are those, and many of them are a bit easier to administer and potentially more effective, and are those being looked at in adult ALLs?
So yes, some of them are. Some of them are being studied in adult ALL. There's also, of course, blinatumomab. So I think what Dr. Klein is referring to is blinatumomab, as many of you may be aware, is a continuous infusion, which is not very easy to administer. So I think people are looking at different formulations of blinatumomab to be given not as a continuous infusion. And then there are other bispecific antibodies that are being investigated as well, both to CD19, but as well as to other targets as well. Yeah.
Thanks. And there was a question about measuring of minimal residual disease in ALL, and as you mentioned, that's something that you didn't cover. Obviously, we only give you 20 minutes, but I think it's an important question. Where does MRD stand? Is it something that you're typically measuring? How do you measure it? When do you measure it? And do you make treatment decisions based on it in adults?
Yeah. So minimal, and I had some slides and I hid them because I was going to run out of time.
That's what the Q&A is for.
So to make sure everybody's on the same page. So minimal residual disease refers to when you're in a remission. So when you look under the when the pathologist looks under the microscope at the bone marrow biopsy, they do not see any leukemia cells there. But when you measure at more sensitive levels, which it can either be done by something called flow cytometry, where you mark the outside of the cells with markers and then send them through a special machine, or now actual sequencing, then you still can find a low level of disease. So that's what's being termed as minimal residual disease. We know that in patients who have minimal residual disease, at the end of the first month of treatment, but also particularly at the end of 3 months of treatment, their outcomes are significantly worse than patients who don't have minimal residual disease. And so if somebody has minimal residual disease after that first month of treatment, after that induction, usually it does make you concerned. And some people will say that that patient needs a stem cell transplant based on that. I think pretty well established is that, we're talking just in the newly diagnosed setting. If after 3 months of treatment, if you have minimal residual disease, I think that you absolutely will, the data would say that you should be recommended to at least be evaluated for a stem cell transplant. Now, and this gets asked of the investigators all the time doing the blinatumomab trials, but we now have blinatumomab, which in addition to being approved for relapsed disease is approved for minimal residual disease. And so I think one of the questions is, if you have minimal residual disease, you get blinatumomab and now you're negative, do you still need a transplant? And I think that's really unknown. And the data just aren't there to guide that answer. I absolutely check MRD. I check it at the end of induction. I check it after, when I'm using a pediatric based regimen, at the end of consolidation. And I use it to guide my treatment approaches because we now have treatment for it. I think it makes a big, it's my big decision point for transplant.
Bone marrow or blood?
Yeah. So I also have a hidden slide about that too. So when you are making those transplant decisions, I do not use blood. You use a bone marrow. So bone marrow testing, either by flow cytometry or there's these next gen, these sequencing, like to use some sequencing approaches to test.
Which do you use?
So I actually use, for those big decision points, sometimes I will use both, which is not a good use of resources, I will say.
I'm just
being recorded. But I mean, I think flow cytometry that's the one that's been around the longest, but it has less sensitivity. If you use what's called a next generation sequencing type method, their sensitivity, sorry, I'm clearly outside the hospital right now. There's like sirens in the background. The sensitivity is a lot better. So I would never, so when I'm making those big decision points, I do a bone marrow biopsy. I would never do flow cytometry from peripheral blood. And I think that's really important. It's a really important point because the sensitivity of flow cytometry is about 10 to the -4. When you go from bone marrow to blood, you probably, hand waving, lose the sensitivity about 1 log sensitivity. And so you're really not getting that level of sensitivity with flow cytometry. Now with some of the—
like one in 1,000 cells versus 1 in 10,000 cells.
Yes, exactly.
Yeah, okay.
But when you're used the NGS, the next generation sequencing, their sensitivity is 10 to the -6th. And sometimes they'll say even 10 to the -7th.
Wow.
There does seem to be, and there was a paper that, again, I had a hidden slide, but a paper recently published that showed that there is a good correlation between blood and bone marrow. So I trust it for monitoring. So when I'm monitoring a patient, such as post-transplant, or if I'm kind of monitoring at a point where it's not going to make a big transplant, no transplant decision point, then I will trust the blood, if that makes sense. But I only do NGS from the blood. A big decision point, I still do a bone marrow biopsy.
That's great. Thank you. Yeah, there were a couple of questions about that. And another question is about like survival statistics that we oncologists are so adept at sharing. You know, the curves that we show are called Kaplan-Meier curves for the crew out there. And maybe you can tell us a little bit about the statistics. For example, you know, do the survival times or event-free or progression-free survival times start at the time of diagnosis or at the time when one reaches a remission at the end of treatment? Are you able to sort of provide a little clarity there? Because I sometimes that can be a little confusing.
Yeah, no, I think that's a great point. So the survival times that I showed at the very beginning, so those are from the SEER database, which anybody can go online and actually play around with that if you wanted, the SEER. And they have all kinds of little things you can play around with their website and get all kinds of data. So that's kind of a national database. That's from the time of diagnosis. So when I was saying those survival statistics at the beginning, those were from the time of diagnosis. When we're talking about the kind of those treatments for the relapsed disease, most of them will start at the at kind of the start of the treatment. Oftentimes, they'll start like kind of right when the patient went on the study and started the treatment. But then there are some, which I don't think I showed any of these, but some of them, well, I guess the progression-free survival. So the time for the leukemia to come back, that starts once they've gotten into remission. So yeah, it can be quite confusing. But when I show the overall survival, that's from the time of diagnosis. When we're talking about treatment, that's also oftentimes from the time of treatment. And when we talk about the time that it takes the leukemia to come back, that's from the time of remission. Oh, Justin, I think you cut out.
Damn mute button. So a couple of questions around transplant. One question is asking what are options for folks who have had recurrences of their ALL after a stem cell transplant. And then the other, and I can repeat it if you need down the road, but the other is about options for older folks to undergo stem cell transplant when they have comorbidities. Are there studies or clinics where these folks can be evaluated and maybe optimized, if you will?
Yeah, so I'll do the first one. And I will say I don't consider myself to be a transplant physician. So we'll take all of these with that caveat. As far as the treatments for the treatments post-transplant for disease that has come back, a lot of the studies and a lot of that data that I showed, they allow patients who have undergone a stem cell transplant. So the blinatumomab, inotuzumab, you could have undergone a stem cell transplant. And a lot of the ongoing studies will allow you to have had a stem cell transplant as long as you don't have any, it's called graft versus host disease. So a lot of the treatments are very, very similar. So whether or not I'm not as up on the transplant, where there's transplant specific trials, there may be, but not that I'm aware of. I know that, I know that there have been, people have been looking at blinatumomab post-transplant, and it seems to be safe and to work as well. But so
what about CAR-T cell therapy after transplant relapse? Is that something that you consider in your folks and your people?
Yeah, so we do still do CAR-T cell therapy post-transplant. And so again, to kind of make sure everybody's on the same page. So when we're talking about transplant, we're talking about, for ALL, we're vast majority of the time talking about an allogeneic stem cell transplant. So that's where you get somebody else's bone marrow. And so the cells that after a transplant, the cells that you have in your body belong to somebody else. So then when the CAR-T cell therapy, as I discussed, what you're doing is you're taking out the healthy immune cells and then engineering them and then infusing them again back into so what you're really taking out is, and I think this is the challenge, is that you're using somebody else's T cells. So you may have more risk for graft versus host, basically because you're activating the T cells and infusing them back in. I think a lot of the data show that we can do this, and we certainly have. I have a patient who, we've done it. We've given CAR-T cell to patients who have had an allogeneic transplant, but that is kind of the risk, is that you're giving somebody their, the T cells back that don't belong in their body.
What do you do with your folks who might be in their, say, later 60s, early 70s, for whom you deem an allogeneic or donor stem cell transplant is necessary? Are there physicians specialized at your center that sort of help you decide whether A, that's the best approach or a reasonable approach, and B, if the answer to A is yes or maybe, how to sort of best prepare them for a stem cell transplant and to get the best results?
Yeah, so I think first off, I think we're getting a lot better at stem cell transplants than we were even like 10 years ago. And so I think our ability to have a patient undergo a stem cell transplant, even with some comorbidities or other medical problems, is really improving. And I think we're recognizing more and more of the less toxic ways to do a stem cell transplant, but it's still a stem cell transplant, and it's still a risky procedure. And so I know at many centers, oftentimes centers will have transplant physicians who are specialized in this, and particularly in older patients. And so I think a big push has been to do a really comprehensive geriatric assessment where you look at all of not just what's on paper, but really the functional status of the patient, and to see if they can, based on that, if they can tolerate the transplant, and then having a more comprehensive transplant approach. And I think some centers are even looking at kind of exercise programs pre-transplant to try to get people as fit as possible, similar to what we do with organ transplants and that sort of thing.
Yeah, that's great. Well, thank you for answering all of our many questions, and again for spending some time with us late on a Wednesday evening. I'm gonna turn it back over to Carrie, who will wrap it up.
Yes, thank you so much to both of you. Very informative. We really appreciate you giving your time. A couple of quick wrap-up items. If you found this Q&A session to be beneficial, I just want you to know we are having 2 programs in February called Leukemia Q&A that will all be Q&A, one on acute leukemias and one on chronic. So we will be sending information about those programs. Also a reminder, we're going to send an evaluation right after this. If you could please take just a moment to fill it out. And last but not least, we will be sending the recording as well as the slides that Dr. Curran presented tonight, in case you want to go back and look something up, to everybody who registered tonight. So thank you so much to all of you, and have a wonderful evening.
Good night, everyone.